Hello and welcome to the module on Family Integrated Care. This module comprises of 3 short sessions. Family Integrated Care is a philosophy and ethos that we practice on the Evelina London's neonatal unit. This is why we feel it is hugely important for everyone to understand what it is and how to practice it. Before we get started on this session, we would be grateful if you could pause and complete part 1 of the brief questionnaire accessible via this QR code. We will ask you to complete part 2 once you've completed all 3 sessions. Our first session is going to focus on what it is like being a parent on a neonatal unit. We're going to start this first session with a poem written by a dad shortly after hearing that his daughter needed to be delivered at 24 weeks.
When the nights are long and the days are short, I spend my quiet times trying to listen for your heart. The fluttering beat is so near yet so far. I'm hoping and praying that you stay where you are, as even though yet you are but a dream, I long for the day that the world will have seen you travel your path with my help where you need. I'll even be happy to serve as your steed and carry you where you ask, though tired I may be. I'll do anything at all to be able to see you healthy and strong and happy in life, so just hold on and we'll see night by night. But know my love too as I urge you to grow, till I can make you laugh loud and try then to show you the best of this life and what you can do. But for now, please just hold on for a few more weeks inside where it's warm and dark, and keep my dreams alive with your glowing bright spark.
We think it is really important that we all appreciate what it feels like to be a parent on a neonatal unit. Parents are just people. They are just like you and me, who are usually traumatised by the experience, separated from their sick baby, and often robbed from the usual pregnancy or birth experience. Parents have told us that they feel redundant, sad, overwhelmed, guilty. They're very scared to love their babies, and they're terrified to hold them initially. Parents feel continually anxious, they feel completely out of control, and have often described themselves as being useless, a failure, isolated, but they are also very grateful that their baby is being cared for. Being a parent on a neonatal unit can happen to any one of us. It is often completely unpredictable and a huge shock. We ask you to bear that in mind when you're talking to parents, as trauma is real and you never know what kind of traumatic experiences parents have had in their lives before. So how can we improve the experience of parents on neonatal units? Well, as part of the NHS 5-year plan, the Neonatal Critical Care Transformation Review suggests parents should be supported to be as involved in their baby's care as possible. Consequently, all neonatal units are expected to change the model of care they use by 2025 to a new model of care known as Family Integrated Care. This is also referred to as FICare. On the Evelina London neonatal unit, we co-produced our FICare programme with ex-neonatal parents and staff. The programme launched in May of 2021. We are extremely proud of what we've achieved so far and believe in parents having the best experience possible during their time on our neonatal unit. So what is FICare? FICare is a move away from traditional neonatal models of care where staff were almost solely responsible for looking after the baby and parents were often treated as bystanders. Parents visited their children during set times, but were not expected to perform caring tasks until it was time to go home, when suddenly they were expected to look after their own babies. What FICare does is to support parents to include them in all aspects of their baby's care and decision-making as soon as possible after birth. It's a way of making parents realise they have a role caring for their sick child and part in their own family despite being in hospital. We ask you to please pause this session and watch the 3-minute video, which has been created to illustrate what our staff and ex-neonatal parents told us was important about a FICare programme before we started to create it. You can find this video on the link on the YouTube page, or if you use the QR code on your phone, it will take you directly there. In session 2, we look at what is family integrated care in much more detail. The British Association of Perinatal Medicine has recently published a framework about family integrated care, in which they describe FICare as a model of neonatal care which promotes a culture of partnership between families and staff, enabling and empowering parents to become confident, knowledgeable, and independent primary caregivers. They describe neonatal units with a strong FICare philosophy as nurturing parents into this role by listening to them, building on their strengths and encouraging their participation in experiences and decision-making to enhance control and independence. But what does that really mean? It means that parents become collaborators in their infant's care and are supported and encouraged to be with their baby and provide their care as much as possible. Parents are integrated as active, equal and valued, respected members of the MDT. Parents share decision-making with the clinical team and are strongly encouraged to be present and participate in ward rounds. Staff adopt a mentorship role to enable parents to become primary caregivers, and parents are provided with education and peer-to-peer support to help build their confidence in caring for their baby from the start. We know that FICare supports parents to have a parenting role caring and making decisions for their sick baby. It allows them to regain some control and recognise that their baby needs them. And most importantly, it allows them to bond with their baby and provide the love that only a parent can. So what is the evidence for FICare and why do we practice it? FICare is inspired by innovative models of care in the resource-limited settings of Estonia. Mothers were supported to care for their babies at the cotside due to lack of trained healthcare professionals. This approach had the unexpected outcomes of decreased mortality, decreased infections, decreased antibiotic use, and increased breastfeeding rates, earlier discharge, and increased parental confidence and well-being. In 2013, 34 years after it was first described by Dr Avek Levin in Estonia, Carol O'Brien and Shu Lee at Mount Sinai Hospital, Toronto, adapted the approach. Since then, single cohort studies and multi-centred randomised controls trials have consistently showed improved outcomes for infants and their parents. As you can see, there are huge clinical benefits for babies. There is increased weight gain at 21 days. There is an increased proportion of babies who receive breast milk at discharge. Generally, babies tend to weigh more at discharge. Overall, there are increased breastfeeding rates and durations, and babies have been shown to have increased mental developmental index and psychomotor developmental indexes at 18 months. Overall, FICare programs produce overall length of stay, decreased time to oral feeding, and decreased readmissions, as well as decreased maternal stress and anxiety, increased parental confidence, increased parent-parent communication, and increased infant-parent bonding. For staff, a study from Glasgow has shown that there's improved parent-nurse communication. They found that FICare programs lead to empowerment in order for staff to design and lead change in their unit, which consequently leads to increased job satisfaction and contributes to more cohesive and social teams. So what do we now expect from parents since launching our FICare program? Well, this is a page from our parent and staff manual, which we'll introduce you to later, which clearly states what we expect from parents. So firstly, we expect them to be present with their baby as much as possible. We're happy for you to explain to parents that the evidence for improved clinical outcomes and faster discharge is based on their baby having at least 6 hours of parental contact a day. We expect parents to be present at important times of medical decision making, such as ward rounds, daily from at least 10 till 12 p.m. We also expect parents to build a relationship with the team based on mutual trust and respect. We appreciate that there will be some parents that are unable to commit to these expectations, and they will consequently receive as much assistance as possible whenever they are able to come. However, our focus is trying to encourage parents to be present as much as possible. What does FICare look like at the cotside? Here we've picked 3 examples of everyday neonatal tasks. What this diagram outlines is how we currently work with parents and the level of collaboration that FICare would take us to. So, if we look at procedures, for example, a blood gas or a cannula insertion, we may prefer parents not to be present, but as we all know, there is no other situation later in life when we would not expect a parent to comfort their own child if they were potentially going to experience pain. So, What FICare allows us to teach parents is how to comfort and support their baby and work with us as a team to help during some kind of procedures. If we go to look at nasal gastric tube feeding, currently parents are encouraged to participate in feeding episodes, but what we hope FICare will do is to stop the variation in practice that parents have when being taught, and also allow them to be signed off and more confident to do the task safely and consistently, no matter the day or who they're working with, to look after their own child. How do we practice FICare as clinicians? It starts antenatally when we're counselling parents whose babies are likely to need to come to the neonatal unit. We need to set expectations and explain the reasons for their presence as part of our team. But we also need to constantly remember that parents are terrified about the outcomes before giving birth, so we'll also need to repeat the information several times once they're on the unit. There is a parent information leaflet about FICare which can be printed off the Trust intranet. We should facilitate a delivery room cuddle as often as it's appropriate to do so. For some parents, sadly, this may be the only opportunity they get to hold their baby, and for others it may be a few days before they're able to cuddle them again. It is our responsibility to make parents feel welcome on our ward. For some babies, the neonatal unit is thought of as their first home by their parents. Many babies are with us for several months, and we want to emphasise to parents how important they are to our team. We need to smile and acknowledge them when they come to the cot side, and we need to respect and include them in all of our discussions. We should learn parents' and siblings' names. We should get to know them as people. We need to listen and respond appropriately and kindly when discussing their worries and fears, remembering that they're traumatised by having a new baby. And we need to explain to all new parents and parents that are transferred in about the expectations of family integrated care, why it is important and what the evidence shows. This slide is about working in collaboration with parents. First off, on a ward round, always make sure you inquire where parents are before seeing their baby. You can always change the order of the ward round if parents are expected to be in soon. And if parents are ever struggling to get in, it's worth considering a virtual ward round, as this is the time that most decisions are made. When thinking about discussions and plans, make sure you include parents in all the discussions on the ward round, but also throughout the day when making decisions. It is important to listen to parents when they're worried about their baby. Parents are often the child's continuity at the cot side, and they know when something is wrong, so make sure you acknowledge and act on their worries. If there's any changes to plans or deterioration, make sure you explain the changes to parents as well as the staff. Prescribe skin to skin in our ward round plans. You can always check it's appropriate, but it's very often absolutely fine to prescribe skin to skin. It's also really helpful if you can help nursing colleagues to take babies out for skin to skin, because often all they need is an extra pair of hands to deal with the wires or the tubes. You can help parents to complete their FICare resources and encourage them to use them. And then finally, it's important to remind colleagues that as a FICare unit, we're aiming to involve parents in any parenting tasks that they would normally do if they were at home. So, for example, cares and feeds can be saved once the parents are in the hospital to do them. This final slide, in session 2, is about sharing decision making. These are some examples of the decisions that we may decide to make with parents together. So, for example, in pink, discussing when to do routine bloods, gases, suction so parents can be around to comfort their baby. In green, jointly deciding parameters to enable respiratory support to be decreased. In yellow, discussing sedation and deciding together whether more or less is needed. And then finally in blue, deciding whether to increase or decrease feed volumes together. What shared decision making is not, is parents dictating to staff what should happen. It's important to stress here that professional decisions, such as a baby needing suction or blood test due to deterioration, are not reliant on being shared decisions. The final and third session of this module focuses on our Family Integrated Care programme on the neonatal unit at the Evelina London and should provide you with all the information that you need to know. The FICare team is co-led by Siobhan Jacks, one of our consultant neonatologists, and Elaine Wood, one of our neonatal sisters, and they're also accompanied by Rebecca, who is our neonatal psychologist. There is also a team of FICare nurses who can be identified by their pink lanyards and are available to help at any point. We are superbly grateful to the wider team of both parent and staff champions who have been responsible for helping to set up the project. This slide is just to give you a very short background to where the project originated and how long it's been going on for. So as you can see, this was a large change management project which has been implemented using a systems leadership approach. We commenced the project in September 2020 and had some assistance from a Darzi fellow as well as the other co-leads. We had an emphasis on improving the experience for parents and for staff, and consequently the programme was co-produced by staff and parent champions. We wanted to start by identifying the need and wants of staff and parents, which then led us to the purpose of our project. This is obviously a very ongoing project. It's still in the infancy and there's plenty of opportunity for any of you to get involved. We've built evaluation metrics into the project so we can work out what is working and what is not working and where we need to make changes. It's a very exciting time to join. We started by holding focus groups with ex-neonatal parents, and as you can see from this word cloud, we managed to collate their feelings, wants and needs from the neonatal FICare programme. What parents wanted to move away from was the feeling that they weren't allowed to touch, care or be with their baby, and the feeling that different nurses and doctors behaved in different ways. Some staff encouraged parents to be present and do all the caring they can, whilst other staff made them feel like bystanders with a purely observational role, telling them what they could and what they couldn't do, or when they could and couldn't be with their baby. We combined the staff wants and needs with the parent wants and needs. So as you can see, the majority of staff wanted parents to be more involved. They wanted a dedicated team, they wanted consistency and standardisation. So what we moved towards was a shared vision and purpose of increasing parental involvement in caring and decision making for their babies, leading to improved clinical outcomes for babies and psychological outcomes for their parents. The work aimed to create a consistent and standardised approach to delivering family integrated care by implementing a FICare programme based around parental and staff need. These are the 3 FICare resources that you need to make yourselves familiar with. On the left-hand side is the Parents Manual. It is called Our Growing Home Story, and every baby who's admitted to the neonatal unit will receive one. Please do familiarise yourself with the content, as there's plenty of opportunity for you to help parents to complete it, starting at admission. All of the nursing staff also know how to complete it, so please make sure you ask them to give you a bit of assistance when you first start on your job. In the middle column, in pink, is the staff manual. So this manual accompanies the parents manual, and it's found in a yellow folder in every nursery. It is essential that you have the yellow folder open when you're talking parents through their manual, as it contains all the information you need to tell them. The aim is that we standardise exactly what we say to parents and the way we help them to do things. And then finally, in the right hand column is a picture of a laminated document called the This Is Us form, which is found at the COT site. Please also encourage parents to complete this and review it on ward rounds, as this is a way for parents to share information about what is important to them and what they would like us to know about their baby. In summary, the aim of our programme is to improve the clinical outcomes for babies and psychological outcomes for their parents. We are all responsible for influencing parental experience on neonatal units. Please remember, parents are not difficult, and it's important not to label them as so. They are scared, tired, stressed and often overwhelmed, and they may ask lots of questions or be very worried, as they want to understand what is happening to their baby in circumstances where they have little control. Parents are the same as us. They're people who've had unwell or babies who are born too early. Parents are not visitors. They are equal, respected members of the team caring for their baby, who provide the love that only a parent can. Parental presence and contact is essential for neurodevelopment, bonding, attachment and social development. Finally, always remember, parents know their baby the best. They are their baby's biggest advocate. We're going to finish this module with a poem from the same dad when he was getting ready to take his little girl home.
The road you've walked till now, it hasn't been so straight. There were times it seemed the end was coming. I could do naught but sit and wait. But the cliff edge that I thought I saw turned out to be a corner, and now I'm sure, my darling girl, the road ends no longer. And walk it with you forever I will, so happy at your side. The courage and the strength you've shown just makes me burst with pride. So home we go and home we'll stay. This will all have been worthwhile. To see you growing big and strong, the whole world will feel my smile.
We hope you've enjoyed completing this induction module. We ask if you could spend a couple of minutes completing the questionnaire you started at the beginning. Once you've completed the questionnaire, please send a screenshot of the certificate of completion to the FICare nurses whose email address is on the next slide. And if you'd like to get more involved with the FICare programme, please also drop the FICare nurses an email. Many thanks for listening.